Now that we have finished the topic on enzymology, we will now be proceeding to another one, which is about electrolytes. Right, so let's start. What are electrolytes? Electrolytes are ions. So that means they are either positively charged or negatively charged. So cations, this is just a review, are ions which are positively charged, and anions are those which are negatively charged. There are some important electrolytes to take note of. For example, sodium, potassium, chloride, and bicarbonate. These electrolytes generally function in the following. So they are involved in enzyme activation, coagulation, complement cascades. They contribute to the osmolality of plasma. They participate in cardiac rhythm and neuromuscular excitations, and so many more. Electrolytes are distributed both inside the cell and outside the cell. So the distribution actually vary. For example, there are more sodium, potassium, and chloride ions extracellularly, while there are more potassium, magnesium, and carbonate ions inside the cell. So, based on this, we can more or less say if there is hemolysis, these substances, which are inside the cell, the red blood cell, will be released. So there will be an increase in potassium levels, magnesium, and bicarbonate. So we can consider those as some kind of interference in the true value. The intracellular fluid, or ICF, contains more protein, more potassium, magnesium, phosphates, and bicarbonate, while in the extracellular fluid, there are less proteins and more sodium and chloride. So there are other fluids aside from this. We have the interstitial fluid and the intravascular fluid. So many different fluids that are distributed inside the different compartments of the body. The osmotic pressure in our body fluid is basically controlled by sodium and water. There are hormones that help in the control of the um, water balance in the body. So one of these would be aldosterone, and the other is antidiuretic hormone. So take note of the effects of these two hormones. Aldosterone can conserve sodium and chloride, while antidiuretic hormone conserves water. There are situations when, whether in certain disorders or no, physiologically, there may be some loss of water. For example, dehydration. Um, for example, if you stay in a very hot place, so most of the water from your body will be removed. Lack of antidiuretic hormone, so this is a case of diabetes insipidus. Loss of water and electrolytes, combination of water and electrolytes. When you have diarrhea, so there is GI loss of water, excessive sweating, burns, burns. So when someone got burned, so the skin will be opened, and it's very easy for the liquid to evaporate, and excess urine excretion. Another condition that results from fluid imbalance is called edema. So this happens when the liquid or fluid accumulates in the tissue space. When we say tissue space, that could be between the skin and the underlying muscles, so subcutaneous tissue. So this can happen when the salt and water is depleted to an extreme. So what are the possible causes of edema? When the protein level is very low, when there is a blockage in the lymphatic vessels, when the sodium is retained, this will have an increased capillary blood pressure. So those are the possible causes of edema. So let's have an example. In pregnant women, so sometimes they experience edema, especially of the lower extremity, because of the growing baby. So this baby puts pressure on the lymphatic vessels in that area that leads to edema. The normal pH of the blood is about 7.35 to 7.45, and this value on the average is about 7.4, and this is very slightly alkaline or close to neutrality. The main factors that control the pH of the blood is this bicarbonate and carbonic acid buffer system. But of course, there are other factors that can control this pH level. For example, the protein levels in the blood plus the hemoglobin buffer system, they are also responsible for controlling the acid-base balance. So this is the most significant. Our pH, the blood pH, is controlled also by the kidneys and the lungs. Okay, so both participate by removing these unnecessary substances like carbonate and hydrogen ion in the kidneys, and carbonic acid in the lungs. Whenever we breathe out carbon dioxide, we are actually removing carbonic acid. The normal ratio for bicarbonate ion to carbonic acid is about 20 to 1. So using this equation, 7.4, the value 7.4 is gotten from 6.1, which is the pKa, okay, plus the logarithm of bicarbonate over the carbonic acid. So that would give you about 7.4 value. So some other mechanisms that can regulate the buffering and of urinary hydrogen ion is the presence of ammonium and phosphate buffer systems. The renal tubular secretion and reabsorption can also participate in reabsorbing important ions and in active secretion or removal of certain ions. What is a buffer? So this is simply usually a combination of two substances, two chemicals, one acid, and the other is a conjugate base. So the action of a buffer is to resist the change in the pH. So there are certain parts in the kidneys that participates, as I've told you. Okay, so there is active secretion. So this happens in the tubules, the distal convoluted tubules. Okay, so they remove hydrogen ions and ammonium ions, and also they can remove sodium bicarbonate and biphosphate in order to control the um, level of acid in the blood, acidity in the blood. There are conditions that may result from a disturbance in the acid-base balance. When the kidney is involved, we call this metabolic acidosis or alkalosis, depending on the case. So what we know about the blood being acidic is when the pH falls below the normal level. So there is a decrease in the pH of the blood, and at the same time, the bicarbonate and the total carbon dioxide level is also lowered. So the most common causes of this condition are the following: diarrhea, diabetic ketoacidosis, which may be found in people with diabetes mellitus, and renal failure. So whenever this happens, whenever the bicarbonate levels and total carbon dioxide level goes down, the lungs will have to compensate. If there is a problem with the kidney, the lungs will compensate. This will simply cause the breathing of the person to be faster. So when you breathe faster, you release more carbon dioxide, and it will decrease the PCO2 level of the blood. Metabolic acidosis is one that is characterized by increased anion gap. So this is like a mathematical relationship among the ions. So metabolic conditions like diabetes, diabetic ketoacidosis, renal failure, lactic acidosis, other renal problems can have this metabolic acidosis. As I told you, this is mainly caused by renal problem. A defect in the renal tubules may also lead to acid-base imbalance or electrolyte problem disorders. So the urine will be characterized by alkaline pH with acidic blood or plasma pH. The consequence of this would be there will be depletion of potassium and bicarbonate ions. So that means that the tubules going to remove these ions from the filtrate, and this will result in an imbalance in their electrolyte and minerals in the blood. Another situation that can happen when there is a disturbance in the electrolyte balance is called metabolic alkalosis. So this is the opposite of metabolic acidosis. So this is when the blood pH is much higher than normal and the bicarbonate and the total carbon dioxide is elevated. So what are the causes of this condition? Excess treatment with bicarbonate salts, prolonged vomiting, renal causes of potassium depletion. Again, the lungs will try to compensate by um, retaining carbon dioxide. So you will notice that the breathing of the person will become slower. So there will be ventilation, hypoventilation. If instead of the kidneys, the lungs are the ones that have a problem, the term that we will be using would be respiratory acidosis or alkalosis. So in the first one, respiratory acidosis, there is a decrease in the blood pH, making the blood more acidic, and the characteristic parameters that you can see would be an increase in the carbon dioxide level in the blood. So the causes of these conditions may be respiratory illnesses like emphysema or chronic bronchitis. In both cases, the alveoli may be damaged, and that will lead to impaired exchange of gases in the lungs. So this will be characterized by hypoventilation and hypercapnia. Some medications, for example, when you are to undergo surgery, so they will give you anesthesia that can depress respiration. So that can also be one of the causes of this condition. So if there is a problem with the lungs, it will now be the kidneys that is going to compensate by releasing more bicarbonate from the blood. So as we know, this is a um, one way to maintain homeostasis. So the other one is called respiratory alkalosis. So this is the opposite. There is an increase in the blood pH and the carbon dioxide level seems to be decreased. There are possible causes of this condition. For example, hyperventilation, when the person is breathing faster than normal, and compensation will be to um, decrease the elimination of blood bicarbonate in the urine. Right, so let's go back to the electrolytes. That's just one aspect of the functions of the electrolytes, that is acid-base balance maintenance. Sodium, the first one. This is a very important electrolyte because it maintains the osmotic pressure in our blood vessels. So this is maintained primarily by the kidneys. Its elimination and its main retention is primarily in the kidneys. The hormone that regulates sodium is aldosterone. So this is also known as the major natriuretic hormone. So that means it is able to maintain or retain sodium. This hormone regulates the blood pressure by maintaining sodium in the blood. Clinical significance, hypernatremia. So when you see this word hypernatremia, so that indicates that there is an increased level of sodium in the blood. There are renal and non-renal disorders. So the non-renal disorders may be dehydration, okay, the loss of water and electrolytes through dehydration, burns, as I told you, when the skin is damaged, it's very easy for the water to be evaporated, and excessive sweating. So the renal causes, on the other hand, can be nephrogenic diabetes insipidus. So that is when the antidiuretic hormone level is low or missing. The osmolality, so that is the concentration of the electrolytes in the serum, and the urinary sodium levels will differentiate between renal loss of water and non-renal causes. The other condition is called hyponatremia. So you know that the sodium level would be lower than normal in this case. There are again renal and non-renal causes. The renal causes are salt-losing nephritis, inflammation of the nephron, chronic renal failure when there is too much water that is in the blood, so that can dilute the sodium level, and nephrotic syndrome that can cause fluid imbalances and edema, which will result in hyponatremia. For the non-renal causes, so if a person is drinking water too much, that is called psychogenic water overload. When there is a cellular shift changes because of acidosis and edema, because of cirrhosis or congestive heart failure, so that can also be a cause for hyponatremia. The next electrolyte is potassium. Potassium is important in the maintenance of cardiac rhythm and contributes to neuromuscular conduction. So if there is an imbalance, it can result in hyper or hypokalemia. This may result in arrhythmia, so there is irregularity in the heartbeat, and weakness. What are the causes of hyperkalemia? So these are the different conditions that can result in elevated potassium level in the blood. Renal failure, the ingestion of diuretics, so those medications that causes a person to urinate more. Hypoaldosteronism, because potassium is retained and sodium is lost. As we know, this is the hormone that is regulating the sodium level in the blood. Hypercortisolism, so this is another hormone that can control the potassium level. Diabetic ketoacidosis, hemolytic disease, or leukemias. What about hypokalemia? So these are the different causes of hypokalemia, or low levels of potassium in the blood. Renal tubular acidosis, could be because of diabetes, hyperaldosteronism, so this is the opposite, retention of sodium, hypercortisolism, so this is too much of the cortisol that is produced by the adrenal cortex, diuretics, the intake of certain diuretics. Okay, so there are also diuretics that keep the potassium, and though there are diuretics that cause the potassium to be eliminated in the urine. Another possibility is vomiting or GI loss. So you may lose some electrolytes in this processes. There is a cellular shift in insulin overdose, and alkalosis can cause hypokalemia. What are the different methods that we can use to measure electrolytes? So we can see here some of the methods. Ion selective electrode, ISE. Using this method, we can utilize the measurement of sodium, potassium chloride, bicarbonate. So this is through the use of electrodes. So that is an instrument. This is an instrument that can directly measure these electrolytes. And then the flame emission photometry. So because sodium and potassium can emit a particular color that can be measured photometrically. And then colorimetry. It's also possible to measure some electrolytes using this method, like chloride and bicarbonate. So colorimetric method can also be used. Atomic absorption spectrophotometry or spectroscopy. However, this is very limited in application because we know that sodium and potassium, maybe you have already taken this up in instrumentation, sodium and potassium do not normally stay in the ground state after stimulation by heat. Ion selective electrodes. So we use the word selective because this is very specific to certain ions. And for example, for potassium, we have what we call valinomycin that is added to the electrode that makes it selective for potassium. So this can be utilized in many different ions as long as we utilize the specific electrode so that it's covered with a unique material. So what will happen, this is the principle in this ion selective electrode is similar to that of a pH meter, wherein when there is a contact between the ion and the electrode, there will be a change in potential. So we call this potentiometry. What we need to remember is that lipemia can interfere with an indirect method of measurement. So for sodium, the ion selective electrode is made of lithium aluminum silicate or silicon dioxide glass compound. Ion selective electrode for potassium, as I told you, is made up of a membrane containing valinomycin, which is an antibiotic. Next is flame emission photometry. So in this case, a sample is mixed with an internal standard, which is usually lithium. The solution is aspirated into a flame, okay, and ions then will be excited because of the heat, and they will emit radiant energy. So for every ion, there is a color that is emitted as a result of heating. For example, sodium is yellow, potassium is purple, and so on. So there is a photodetector that can detect the emission, color emissions of these electrolytes. What are the specimens that are used for sodium and potassium? We can use serum or heparinized plasma, but we cannot use hemolyzed sample as we know, because of the distribution of potassium and sodium in and outside the cell. So we also need to avoid lipemic samples, and we need to separate quickly the serum or plasma from the cells. Okay, CSF determination can be done for sodium but not for potassium, and urine sample without preservative is possible. So we have here the quality control concerns. It's the same thing as for other substances. So listed in this slide would be the different possible sources of error for the analysis of sodium and potassium. For example, hemolysis, if we use stimuli samples, so that can lead to um, higher potassium level, falsely elevated potassium levels because of the distribution of potassium and sodium inside and outside the cell. We need to quickly separate. So if we fail to do that, the separation of plasma and the cells, so the components that are present inside the cells may actually leak out and lead to again false results. Anticoagulants can also interfere with the test as other than heparin. Prolonged use of tourniquet because of hemoconcentration, lipemia, which can interfere with the measurement, and maybe other possible errors of in the analysis. For example, if there is a problem with the instrument, okay, the selective electrode, and so on. Right. So with the use of the ISE system, this will dilute the sample, and with this diluent that is added to the analysis, we call this indirect measurement. This can actually be affected by hyperlipidemia or hyperproteinemia. Normal level, we can see here 135 to 145 millimoles per liter and 3.3 to 4.9. But remember that this level is just for reference purposes because it can vary depending on the method that is used and in different countries, different locations. Right, so we need to report and document. This is to avoid post-analytical errors. If you remember, once the result is finished, we have to make sure that the same information will reach the doctor or the patient. So make sure that the correct information are included in the report and submitted in a timely manner. Chloride can contribute to the acid-base balance by the so-called isohydric shift. So this is a buffering action to of the hydrogen ion and bicarbonate and many other ions intracellularly that results in movement to the extracellular fluid spaces. So this is the movement of chloride and it balances bicarbonate ions. In cases of dehydration, like severe diarrhea or burns, it will result in hyperchloremia. And in cases of hyperaldosteronism, this can also result in the same condition because aside from sodium, chloride is also retained. In cases of excessive urination, excessive sweating, hypoaldosteronism, so chlorine is lost in the process, so that will result in hypochloremia. Chloride is also possibly measured using ISE. Okay, but most of the time this can be done, the measurement can be done using coulometry. So this is when chloride is titrated with silver ions that form a precipitate. The time of titration is proportional to the amount of chloride present in the sample. This is best used for the measurement of chloride in sweat. Okay, historically, this is a very important method for chloride determination. Okay, there is another method. This is a chemical reaction involving mercury thiocyanide plus chloride will form mercury chloride and thiocyanide. The thiocyanide plus ion can form ferrous thiocyanide, which is possibly measured in the spectrophotometer at 480 nanometers. Specimens that can be measured in chloride analysis are serum, plasma, heparinized plasma, urine, CSF, and sweat. There are different possible sources of errors, and again, it has something to do with interference because of anticoagulants and the presence of protein that can encode the electrode. In the spectrophotometric method, poor calibration or instrument problem. So those are the possible sources of errors. So quality control is the same for other substances. Normal values or reference range in adult in an infant. So adult is 98 to 107 millimoles per liter, a little higher for an infant. 98 to 113, and in the urine, so in an adult that's about 110 to 250. Infant is much lesser. In a child, much lesser, 2 to 10 and 15 to 40 respectively. CSF, we can also measure about 118 to 132, slightly higher than in the serum level. Infant is again 110 to 130, a little higher than in the serum level, and in sweat, that's about 5 to 35 millimoles per liter. Okay, reporting. So we want to avoid the post-analytic errors. We have to make sure that the information we provide is correct and released in a timely manner. Right, so logging or recording important information in the book is very important. Okay, so I would like you to have this as an assignment. Why is chloride levels analyzed in sweat? So I want you to explain the condition associated with chloride in sweat and possible short discussion. The next one is bicarbonate. We talked about this a little. Bicarbonate and carbonic acid is like a part of the buffering system in the blood. So the following may contribute the level of bicarbonate in the blood. For example, carbon dioxide level in the blood would make up the majority of the carbon dioxide in this process. It's a major component of metabolism that regulates the pH of the blood. As I told you, this is part of the buffering system. Clinical significance, if there is an increase in blood bicarbonate levels, it could be because of metabolic alkalosis or a compensation for respiratory acidosis. On the other hand, so we have the opposite result. If there is a decreased blood bicarbonate, it could be because of metabolic acidosis or compensation for respiratory alkalosis. How do we convert bicarbonates? So TCO2 gas electrode can convert bicarbonate to gas to CO2, and the CO2 will diffuse through a silicone membrane and it will react with bicarbonate and carbonic acid buffer. The amount of hydrogen ion produced is proportional to the concentration of carbon dioxide in the plasma. This is already blood gas analysis. Okay. So we can see here an example of that electrode that can detect carbon dioxide. So it's made up of the same reference electrode, and there is a specific electrode for pH. Okay, and so that is the bicarbonate carbon dioxide electrode. Photometrically, we can also measure carbon dioxide by utilizing this chemical reaction. Bicarbonate plus urea in the presence of an enzyme, urea amidolase, will form ammonium, and this ammonium will be made to react with NADPH. And then in the presence of glutamate dehydrogenase, can oxidize the NADPH to NADP plus free hydrogen, and there will be a decrease in absorbance that can be measured at 340 nanometers. Samples for bicarbonate can be arterial sample and venous sample. So this is most likely arterial specimen. So heparin is the arterial is the anticoagulant of choice for whole blood sample. Possible sources of errors are the following: specimen errors, so wrong anticoagulant. If we fail to keep the specimen stoppered because it will leak, the carbon dioxide will leak when the specimen is not fresh anymore, when there is hemolysis. What else? Analytic errors because of possible contamination of the membrane with protein, poor calibration of the analyzers, right? So reporting errors when we use the wrong reference range, and if we use the wrong sample in the reference range. These are the normal reference ranges. Venous sample is 22 to 29. Serum sample, arterial sample is lower, 21 to 28. Whole blood arterial sample is 22 to 26 millimoles per liter. Right, so again, we want to avoid post-analytic errors, so we have to make sure that the information we provide are correct and submitted on time. We have to document properly by recording the information in the logbook and retain that information for some years. An ion gap. So the sum of the negative ions and the sum of the positive ions, cations, should be equal more or less. Okay, so the difference is called an ion gap. But most of the contributing ions are the major ions, but there are also some unmeasured ions, which is about 15 millimoles per liter. Right, so significance of this anion gap. In many cases of metabolic acidosis, we observe that the anion gap is higher than 20. And this is because of the deficit in the bicarbonate. So that means there is less of the bicarbonate ions and the presence of organic acids like acetoacetic acid, lactate, salicylate, formate, or glycolate. Sodium, an increase in the sodium relative to decrease bicarbonate will also increase the anion gap. So that is the reasons for a change in the anion gap. So decrease anion gap may be because of sodium being low and increase in chloride and bicarbonate. And since this is a rare case, this can also be seen in rare electrolyte imbalance. Right, so most of the time when there is a decrease in an ion gap, it could be because of technical problems. So an ion gap is actually a calculation of the difference between anions and cations. This represents the anions, put them together in formulas, and chloride, bicarbonate that might be present in the sample. This is used to estimate the acid-base balance and electrolyte disturbances. So the formula that we normally use would be sodium plus potassium minus chloride plus CO2. So we need to know the uh, values of each of the ions, and the reference range is about 10 to 20 millimoles per liter. We can also use another formula, which is sodium minus chloride plus carbon dioxide, but this is now replaced with the new formula with potassium. So, interpretation of results. There are many abnormalities that affect the electrolyte. We want to classify these abnormalities and compare the results to the reference ranges. The critical values can actually indicate a life-threatening situation due to the abnormality, and they are typically established at each institution. But, okay, there are critical values that we have to remember. So, if the sodium level is higher than 160 or lower than 120, if the potassium level is higher than 6.2 or lower than 2.8, chloride higher than 120, less than 80, and higher than 40 for upper limit for bicarbonate, and lower than 10 for, again, for bicarbonate. So this may indicate a life-threatening situation, and you should this should be flagged in order for the attending physician to uh, see the result immediately. Okay, normal levels, if it's higher or lower than this, so that could be a problem. Sodium 135 to 145, potassium 3.3 to 4.9. I remember it was 3.5 to 4.5, now it's 3.3 to 4.9. 98 to 108 for chloride, bicarbonate 22 to 28, and 10 to 24 anion gap. So this is the last slide for this presentation. Thank you for listening. These are the guide questions that you might want to ask yourself and determine if you have understood the content of this presentation. If not, you can also always repeat the um, video. You can always check the video again. Thank you for listening and watching.